Thank you very much to the organizers to have the opportunity to talk to you today about skin as the largest organ. And because skin and wound care, we believe, is an interprofessional team necessity, Dr. Gary Sibbald and I will be co-presenting to mirror the interprofessional team. Here are my disclosures, none of which I believe are relevant for this particular presentation.
Okay, and my disclosures are really mostly government for Project ECHO, skin and wound, chymoseptine, compression dynamics, and Health Quality Ontario in the past.
So our next slide is the objectives, which we hope to cover with you this morning. We want to review the skin anatomy and physiology across the age continuum and explore the impact of age and color tone for clinical practice. And while on our disclosure slide and our introductory slide, we talked about some organizations that we are affiliated with, what we say today is our own thoughts and has nothing to do with any of those organizations. So the next slide, we're going to jump right into the skin. And we both believe, we love the skin. We think the skin is a very important organ, the largest external organ of the body. And sometimes it's not given the respect that it probably needs to have, given all that it does for us. And you can see listed here many, many things that it does. Our immune surveillance, for example, and a lot of allergic responses manifest itself on signs on the skin. It's involved in temperature regulation and heat production. It controls the evaporation, so it's involved in hydration for us. It stores substances. It needs an adequate water content, so it's involved in moisture balance. And it's a manufacturer. It synthesizes vitamin D. Gary, as a dermatologist, is there anything that you want to add to this
Let's look at the next slide, and it tells us in more detail that the epidermis forms a protective barrier and it keeps bacteria out. And this is with atopic dermatitis, that barrier is broken down. It protects us against water and sun exposure, makes new skin cells, and they start in the basal layer of the epidermis and gradually move up over 28 days. It facilitates the immune system, and the Langerhans cell is part of the skin. And that cell can actually process antigens and migrate to the regional lymph nodes. And it provides skin color through the melanocyte that you'll hear about a little bit later. In the dermis, you have collagen and elastin that gives us some of the tensile strength. It grows hair. The hair follicle goes right down into the subcutaneous fat tissue. And it detects temperature, differentials, itch, and pain. The subcutaneous fat, or the third layer before muscle, cushions and connects muscles and bone to the skin, and it has some partial regulation of temperature. Next slide. Here is the stratum corneum with an acid mantle. And this is very important because a lot of bacteria really like an alkaline environment, and especially organisms like Pseudomonas. And although the organisms are on top of the skin, they're also in the first layer of skin. And organisms can contaminate and colonize the skin even before they cause any damage. So we do have a normal skin flora, which is important to remember. Elizabeth, why don't you take the next slide?
Yeah, I'd be happy to do that. And I think that sometimes we forget how important the skin is to the whole human being. And I really like this quote from the article by Sherman and Carmel, which really reminds us that besides all the physiological things that the skin does, that it really also relates a dynamic interplay of emotional and cultural influences. And we think about it. We make a lot of judgments about people based on what their skin looks like or doesn't. And even from a cultural point of view, there are rituals involved with the skin at certain milestones in life. There are people that do adoration of the skin by tattooing and piercings, for example. So we need to remember what the meaning of the skin might be to people. And then when certain problems happen with the skin, how it's not just the physical, that the spiritual and mental point of view, an emotional point of view needs to be considered. And I think one of the things that intrigued us, the two of us, had to do with a practice reflection that we published in Advances in February of 2023. So on the next slide, we had adapted the medicine wheel that was used in the First Nations in Canada. Thank you, sweetie. For the Indigenous people in Canada. And you can see here that it really looks at 4 dimensions. And Gary, you had spent a lot of time looking at this from the CanMed competencies in Canada. So maybe you'd like to talk a little bit more in depth about
And
this.
this is more universal than Canada. And a lot of First Nations have variations on the medicine wheel. The mental, or if you like, your expert knowing, is really what Bloom's taxonomy is about. And in CanMeds, it's the medical expert and scholar. The physical relates to your communication, collaboration, and leader. And the emotional part is the health advocate and professionalism. But there's a whole new area here called spiritual. And within this medicine wheel, there are 5 spoke attributes: honoring, valued, connectedness, empowerment, and self-actualization. And as you move towards the center, through the 5 layers of each of these 4 quadrants, you come to a balance. And the medicine, this is not spirituality of going to church or a synagogue or a mosque. This is really spirituality, respecting the land, respecting the stones, the rivers, the forest, and really keeping a balance in nature as well as a balance within humankind. And I think we've got a lot to learn from the medicine wheel. Next slide.
I like the notion of balance very much, and I like how taking that medicine wheel and applying it to the skin, to me, is really resonates what I think that as skin protectors and skin healers, we are all about. This we modified this figure that was previously published in an article in Advances in Skin and Wound Care in 2018, just to emphasize the importance of pH again with skin. And as I think everybody knows, for the skin likes an acid mantle, so it's in the acid range, as you see depicted here. And the pH of the skin, of normal undisrupted skin, is different for adults, 4.0 to 6.0. While as newborns, as you see, their skin is slightly higher in the range, being in the alkaline, depending upon the anatomical site and the age of the infant, ranging from 6.34 to 7.5. So that has implications in terms of skin health and skin care that is already a little bit over on the alkaline side. So be careful what kind of products that you're using on anyone's skin, but particularly more so in the newborn. As we have mentioned before, remember that preserving the skin function is important. and that Gary had mentioned about the reproductive layer of the skin being the stratum basale, and that's where the keratinocytes move up to the outer layer of the epidermis. And remember that as they're transformed biochemically, that's where the cells become keratinized, and that's what creates that hard skin barrier that protects any organisms from getting in, which is so important as a function of the skin. So let's look at the next slide, please. In terms of skin across the age continuum, and it is different depending upon your age. So let's take a look at some of the major differences on the next slide that will impact on whatever your population is. So the stratum corneum is almost absent at 24 weeks of gestation. So by the time in the development of the baby at 30 weeks, it's 2 to 3 layers. And skin is thinner than adult at full term, being 10 to 20 layers. So what does that mean? So if you're caring for a preterm or an infant at birth or a young baby, there is an increased risk of transepidermal water loss. And also importantly, there's an increased absorption of topical agents. So some of the things we know from care of baby, since the skin is immature, if you will, temperature regulation is not as advanced as it is in adults. So that children tend to have higher fevers because of that. And also their capacity to sweat. Remember, the sweat glands are in the skin. That is going to be less, and it's actually correlated with the gestational age of the child. Now, with adults, they have a higher level of alkaline ceramides, which help keep the skin intact. And I know, Gary, you'll talk a little bit more about that in a second. We also see that the dermal-epidermal junction is different in adults, and I'll show you how that translates and is important to skin tears. But if you think of the epidermis and the dermis with ready ridges being interlocked, and as these ridges become less high and are more flattened, it's very easy then for the epidermis to be pulled off, if you will, from the underlying dermis. The pH becomes less acidic, the skin wrinkles, and we're going to show you a picture from one of Gary's patients in the next slide on senile purpura, which I'm not sure that that's the best name, but that's what it's called. And that it takes longer time for the epidermis to turn over, if you will. As Gary mentioned, it takes about 28 days for the keratinocytes to migrate up to the outer layer of the epidermis, and the cells are renewed. So it takes longer for that journey to happen. Is there anything else you want to talk about alkaline ceramides or anything, any points before
Let's do it as we go through the next little series of slides. So on the next slide, you can see that this person has got a very superficial purpura where you see the more superficial red spots, and then a much deeper purpura, probably from the veins at the dermal subcutaneous junction, and you see the larger purple patches here. And it's much more common on sun-exposed skin because the collagen's damaged, whereas purpura in a younger patient can very well occur due to trauma on the inner aspect of the arm, as you see here in this younger patient. And often that purpura is called photopurpura because it is the sun damage to the collagen and the aging that makes individuals more susceptible. On the next slide.
Before you go to the next slide, I just want to mention that the reason why we're showing you these pictures is that if you are dealing with population where you see this purpura, that the work of ISTAP has been published, that purpura are a risk factor for development of skin tears.
Here we see the dermal epidermal junction and the impact with age. So if you look at the red line that's circled in a young individual, you can see the wavy nature to that line. And the dermal papilla, okay, are sticking up between those projections of epidermis down into, and that's called the reticular dermis, okay, or sorry, the papillary dermis with the reticular dermis underneath. Whereas in the older individual, and they're much more susceptible to purpura and to skin tears, you'll see that we've lost those papilla. And so you see some very dry skin, you see some hyperpigmentation, post-bruising, and the susceptibility to skin tears, or there is a bandage over one of those patients' legs.
Actually, that was her arm. And I'm sure most of you who are familiar with the ISTAP classification system recognize this as a type 1 because it's just a linear opening, and most of the skin tear bed is covered with the skin flap. And the patient put on a silicone bandage, and within a week you could see that it had healed up very nicely on her arm. She did need to, she was in a state in the US with a lot of sunlight, and the need for skin protection was emphasized to her, as well as hydrating the skin in general. But we thought having a clinical example would help you to understand the importance of what happens in older people in terms of the dermal epidermal junction. On the next slide, we had mentioned this concept a little bit before in terms of the ability of the skin to absorb substances and how that's particularly important in infants, since their skin is able to, is not as mature, so the absorption of materials is much higher. So Gary, as a dermatologist, I know you'd like to talk a little bit about some products, but we wanted to emphasize that you really need to know what substances are in any product that you are putting on somebody's skin because of the ability to interact and absorbency of a product.
Yeah, and in the case of Fusidin, the ointment contains lanolin. And lanolin in a normal person is a moderate allergen. It's a stronger allergen if you have atopic dermatitis, which is eczema, hay fever, and or asthma. But if you've got a chronic leg ulcer or chronic wound, lanolin becomes a strong allergen. And trying to look at the common allergens, which may be nickel, cobalt, lanolin, and even some of the topical antimicrobials. And that's why we don't use Fusidin ointment, say, in a wound, and you don't get bacterial balance and you don't get moisture balance because it only covers gram-positives, not gram-negatives, not anaerobes. So the topical antisepsis is better. If you're going to use an ointment, the mupirocin ointment does not contain lanolin. Next slide. Here you see dark versus light skin. They both start with a melanosome in the deep dermis, and they are attached. The pseudopods are then either situated in the epidermis, or the melanocyte may be sitting in the superficial dermis, with pseudopods going up to a number of keratinocytes or epidermal cells. And they deposit pigment from the melanocyte by transferring melanosomes into the keratinocytes. And in dark skin, the transfer is larger, and they are eumelanin. And if it's a lighter skin, the melanosomes are pheomelanin, and they're often smaller. And this results in the degree of pigment that you may have in your skin. On the next slide, skin in dark skin tones have a higher transepidermal water loss, drier skin. And there's a lack of education for a person with dark skin tones, and often pictures of dermatological conditions don't show the brown and the black skin as often as you may see it in white to olive skin. Next. And melanocytes and melanin layers of the epidermis produce the pigment melanin, which is then transferred to the epidermal cells. And the cells migrate up, but they carry that pigment right up until they die within the stratum corneum. Next slide. And look at this tone, and you can see that if it's not exposed to ultraviolet light, it's lighter than if it's exposed to ultraviolet. So you often assess skin tone in unexposed parts of the skin. Next one.
And skin tone varies along the person's anatomical body, so that when you're looking at the skin, it's not going to be the same in areas exposed to the skin or in other areas, depending upon the thickness of the epidermis, which does vary, for example, on the soles of the feet, the palms of the hand, for example. So you do need to remember that. And I think that it's a very good point in terms of the ability to visually assess the skin, particularly across the diverse skin tones or colors that we see in humans. And one of the most important things is to have adequate lighting so that you can see what's going on. You want to avoid fluorescent lighting, since that can add a bluish cast to the skin and make it more difficult to really see what's going on. A more appropriate lighting reported in the literature includes halogen lights, and there are even some that you can wear as a headband so that your hands are free to look. People have used flashlights and cell phones and even pen lights to have adequate light to see. On the next slide, we want to remind people that you want to really compare the area to be assessed to the surrounding area around the area to look for problems with the skin or changes in the skin that you might miss without adequate lighting and adequate looking for opposite area laterally if possible, and to look for any unaffected area. And Gary, do you want to talk, although we do have another slide coming up.
Fitzpatrick. Yeah, I will.
Fitzpatrick.
Yeah, and Fitzpatrick was a way that responses the effect of ultraviolet light on the skin. And Fitzpatrick 1 always burns and never tans. Fitzpatrick 6 on the far end usually only tans and very seldom, if ever, burns. In between, type 2 skin will tan slightly but usually burns. Type 3 usually tans but may burn initially. Type 4 is olive skin, and this is a darker Mediterranean type of complexion. Type 5 is yellow-brown skin, and type 6 is black skin. And you're going to need higher doses of ultraviolet light for therapeutic effects, and you're much less likely to develop skin cancers. So the reason I like the Fitzpatrick system is that we have a system where we can relate functionality to skin tone. And we know that the tanning response, which you see in type 2 through type 6, always darkens the pigment from what is the normal pigment, and therefore where you should look at relatively unexposed skin to look at the Fitzpatrick skin type. Next slide, Elizabeth.
And that was developed by a dermatologist many, many years ago. Dr. Fitzpatrick was a dermatologist, correct?
He was the head of dermatology, Thomas Fitzpatrick, in Boston at Harvard.
Yeah, so it's been around and used in dermatology for a very long time. So one of the things that when you're looking at skin, particularly the importance of communication of skin to other healthcare professionals, is that to use a standardized, valid, and reliable scale or tool, whatever word you want to use for it, that helps you to classify skin tone in terms of pigmentation, just in terms of there is a difference in the characteristics of the skin. So on the next slide, here's the Fitzpatrick again, in case you want to add anything else. But there are other scales available that have been used in clinical practice. In nursing, probably the one that I've seen used by some people is the Munsell color system, which has lots of blocks of color on it. It's quite involved to use. It has many, it's more than 6 types in terms of the colors. And recently, the British Association of Dermatologists has published the Humelin Human Color Scale. It is in the process of being more research done on it to see how reliable and consistent it is, but you can read more about it from the British Association of Dermatologists.
And I think my comment on that, Elizabeth, is that I can match in the Fitzpatrick scale form versus function and design, looking at how many moles people have and looking at how much skin damage they've got. Whereas in the other two systems, it doesn't lead me to an approach to treatment and counseling for these people. So, it's going to take a long time before somebody develops something as useful as the Fitzpatrick from a dermatologist point of view. I'm not saying from a nursing point of view.
Well, what I'm saying is I have always believed that the only reason to classify something and have a system is if it helps drive your care and your practice. So I think that I value your comment that you're saying very much, that if it helps you in terms of determining your care strategies, then that's a useful tool, that's the reason why we do classifications. So it drives practice and care. So on the next slide, perhaps this was mentioned by an earlier presenter that talked about skin tears and skin tone, but it's important to emphasize and repeat certain important facts. And you might want to download and look at this document made available from Wounds International on skin tears and skin tone. And they actually have a scale in there, which they adopted from the work of Owen Robinson from 2015, which again has the different colors. And we're just making you available of what's out there with resources that might be helpful to you. On the next slide.
So we have reviewed the skin anatomy and physiology and shown how it changes across the age continuum and explored the impact of age and color tone for clinical practice. Elizabeth?
Yeah, and I hope that we have given you some new insights about the amazing, complex, and important functions of the skin and how it can help you in your practice to protect people with vulnerable skin from developing skin tears. And I know the other presenters will talk a lot about treatment of pressure injuries as well as skin tears. Thank you very much.
Have a good day.